PSMA PET scan has really revolutionized our care of prostate cancer patients, as you know. Not only is it the most sensitive diagnostic modality we have, there is also, radioligand therapy for patients who have sort of more end-stage disease. And so my session was really focused on the role of PSA in the perioperative period. So we use it to stage patients before we take them to the OR. We use it in the biochemical recurrence setting. Where else are we using it along that spectrum to help personalize or improve our care for patients? And, one of the first things to highlight is, UCSF has really been leading the charge on a lot of this work. And one really exciting application of PSMA is actually an intraoperative fluorophore. And this is work that's led by Dr. Hao Nguyen and Dr. Peter Carroll, and has just completed a phase 2 comparative study looking at the use of a PSMA conjugated fluorophore. And so, intraoperatively using robotic surgery, there's different wavelengths of light that we can kind of flip on and flip off, literally like a switch. And at a certain wavelength, you can excite this fluorophore so that anything that is PSMA labeled glows green. And so you can imagine that this really can help guide lymph node dissection, margin status, resection of all visual residual disease. And so this trial has looked at, what are the rates of downgrading of positive margin with the use of a PSMA conjugated fluorophore. And I think, this is really has the potential to really revolutionize what we do with robotic surgery, which in and of itself is a great innovation. One of the most challenging things about prostatectomy is understanding the margin. And, you're in, micrometers of space between preserving nerves and maintaining a cancer margin. And so something that can help you intraoperative to visualize where that plane might be could really revolutionize our operation and optimize our outcomes. So I think that's one area that I focused on that I think is really, really exciting and the next big thing. Another area that we've looked at here is more kind of clinical outcomes, looking at how PSMA PET in the biochemical recurrence setting has actually altered our salvage therapy approaches and potentially longer term cancer specific outcomes. And so, when a patient has had a radical prostatectomy, their PSA is detectable again, unfortunately, and potentially rising. In the past, we would use conventional imaging, CT, bone scan to see if we could localize areas of disease. Now we're using PSMA PET again in this setting. And the question is whether or not, positive findings on a PSMA PET has altered our salvage treatment regimen. And in fact, what we found in a study of over 350 patients who'd undergone either a PSMA PET scan or conventional imaging at UCSF in a biochemically recurrent setting, our approach did change. Okay, so we're seeing more targeted radiation therapy, for example, to visible sites of disease outside of the traditional prostate pelvic bed radiation template. We're also seeing maybe less hormone therapy use in a salvage setting because maybe the thinking there is, look, if we can just spot radiate a visible site of disease, bring that PSA back down to zero, maybe we can avoid the morbidity of systemic hormone therapy in these men. So treatment patterns have changed as a result of our imaging modality. What we found, interestingly, however, is that there haven't really been any changes in second biochemical recurrence after that, meaning that the change in treatment plan in the salvage setting hasn't yet translated into longer term cancer control outcomes after that. I'll say that the data there is quite premature still. So our median follow-up time for men who've had conventional and CT imaging is about 5 years, as compared to 4 years for men who've had the PSMA PET scan at biochemical recurrence. So there is still a possibility, given how slow these events occur in men with prostate cancer, that there could be some separation later on for men who've had PSMA PET scans. I'll say that even if the two outcomes really are not too different in the long term, perhaps you still save on some morbidity for these patients by tailoring their treatment based on your imaging. But I think depending on where you stand on that debate, it could either make a difference or it could be the same, depending on what imaging that you use. So that was one other finding that I presented at the conference. The third sort of opportunity here, leveraging PSMA PET or sort of PSMA as a target, is neoadjuvant therapy for patients with high risk disease before radical prostatectomy. We know that we're operating on higher and higher risk disease for a number of different reasons, and there are men with oligometastatic disease with positive lymph nodes on preoperative PSMA PET who are now taking the surgery. We know that men who have high risk disease are more likely to have biochemical recurrence and less likely to have long-term cancer control even after undergoing surgery. So this provides kind of a clinical need for doing more systemic therapy prior to radical prostatectomy to see if you can downstage the tumor, improve your chance of having a negative margin, maybe treating micrometastatic disease before consolidation. And so that provides the impetus for doing some of these neoadjuvant studies. Um, the the other opportunity of doing these neoadjuvant trials is having a pre and post treatment endpoint, where you're collecting tissue both at surgery and at the initial diagnosis. And so, with Tom Hope, Cornelia Ding, Dave O, and many others, there's been a neoadjuvant trial designed to compare lutetium-targeted PSMA therapy with actinium, conjugated PSMA therapy to look at whether or not there are actually differences in alpha and beta particle treatment targeting PSMA and comparing absorbed dose at the time of prostatectomy. So, the primary endpoint for this study is to look at absorbed dose of, the radioligand therapy at the time of prostatectomy. An important secondary outcome is biochemical or pathologic response. And so, the neoadjuvant trial gives us an opportunity to see what's actually happening at the level of the tissue and comparing alpha versus beta treatment in a surgical cohort.